Thank you everyone
Okay.
for joining us. My name is Stephanie Snow. I'm the president for Texas Association for Clinical Lab Science. I'm co-hosted with my president, Debbie Fabian, who will be monitoring this. And we're going to provide a PACE credit for you guys, but we are going to give the PACE credit at the end of the session. Okay, so again, this will be recorded. Please hold questions until the very end. We're going to have time and a lot of time for your questions. You can either do it through chat or you can press the little hand icon if you have a question. Please turn off your audio. I'm sorry, please turn off, your audio, your microphone, and your video while the presenter is speaking. This is going to help with bandwidth and any kind of distractions. Again, my name is Stephanie, and we are going to introduce our speaker. His name is Casey Laird, and very knowledgeable profession in our industry. He is the Assistant Regional Director for a healthcare facility for compliance in Austin. We are very excited for him to come on and speak to our organization. So with that being said, I'm going to give it to Casey. Thank you.
Fantastic. How do I get that little guy? Oh, there we go. Technical difficulties, just a second. See if we can get that. Now we're talking. Good evening, happy lab week. My name is Casey Laird. I'm working in health facility compliance for Texas Health and Human Services. I'm really excited to be speaking to you guys today. I'm spreading the gospel about one particular CLIA regulation. If you didn't have enough of them, this one's probably my favorite. And it's just something I kind of found later in my career. And this has been a conversation. This whole thing kind of got kicked off with a conversation with me and Stephanie talking about just kind of the gaps that we find in this and quality control. And so I'm gonna get started. A couple of disclosures and disclaimers. I don't have any financial conflicts of interest to disclose, not invested in anything that might be in this presentation. Also, I work for Texas Health and Human Services, but this presentation wasn't endorsed or approved by CMS or Texas HHSC. So just want to let you know that I'm allowed to be here, but I didn't get any particular blessings on the content. This is part of my opinions and my personal background and anecdotes. I graduated from Texas State in 2006. Eat 'em up cats. My first job out of college, I was a generalist, worked on every bench, micro, blood bank, chemistry, hematology, phlebotomy. I worked the core lab at a children's hospital for about 4 years, and then I moved into flow cytometry. I love flow. Flow is a big passion of mine still. And then I got an opportunity to be a CLIA surveyor. I worked as a CLIA surveyor for about 4 years. Traveled a lot, went all over the country and learned a lot. I left that position in 2015, I believe, or 2019, and then worked as a laboratory manager for a little while. That was a cool gig too, but I had an opportunity to go back to the state, and that's kind of where my heart is. I would encourage anyone to work, in the state service. So currently I'm Assistant Regional Director for Health Facility Compliance in Austin, Texas. I have 2 programs. We do federal certifications for rural health clinics, community mental health centers, outpatient physical therapy, things like that. And then I also have a small CLIA team that we help manage. And we have basically all of West Texas, and we go to laboratories and do complaint investigations and recertification surveys. And so that's kind of my background. The intended audience for this, technical consultants or supervisors, general supervisors, lab directors, other surveyors who maybe you're a cap inspector and you're part-time, or other surveyors who maybe find this guidance, and anyone who actively manages a quality control program. This is just such an important concept, and I really want to kind of drive home the patient-centered part of this. So the focus of this talk is on one particular CFR. There's quite a bit in CLIA, but we're going to talk about what we call a DTAG, D5783. That's the way that CMS organizes the regs. And if you Google the CLIA interpretive guidelines, want to find this particular tag and follow along, you can put in D5783. And I'll talk about a couple other regulatory obligations as well. I'm going to discuss kind of the from my perspective how we do some survey strategies and we identify kind of patient safety risk. I've got a couple of examples, and then I'm going to talk about what we look for in a plan of correction or allegation of compliance whenever we've cited a lab. So here is our reg. Basically, the premise here is that we have it's a requirement that we document all corrective actions whenever calibrations or quality controls fail. And this is always something that's kind of, really mesmerized me as a med tech, because I think med techs or medical lab scientists are really problem solvers at heart. And, it feels good when something's wrong and you kind of put that puzzle back together and, maybe we celebrate, quality controls finally in. But the other part of this reg that's so important is that all patient test results obtained in an unacceptable test run, and since the last acceptable test run, must be evaluated to determine if patient test results have been adversely affected. And this was something that I went through, a large part of my career, focusing on fixing the out of control assay. But I don't know that it really ever occurred to me that I needed to be looking backwards and saying, what happened and how did that assay, become out of control? And, did we have any patient impact? Given this opportunity, why I wanted to discuss this particular CLIA reg, there's a lot of regulations in there that are, writing procedures or writing quality control or how often. This particular reg kind of sits in a special place in my heart because, the lab's part of the, patient care team. It's one of the most patient-centered regs in there. It makes you kind of look back and evaluate if you've had an assay that's out of control or a calibration that has drifted, that you are really making sure that your results that your lab's turning out are accurate. It kind of hits into that problem solving, that puzzle solving kind of nature. And the one thing I've found is there's just not a lot of resources that discuss this issue very well. And this is kind of my own little personal library. These books are fantastic. You can tell I'm a Westcard fan. I buy everything that comes out of there. Lots of chemistry and lots of lab, stuff in my library. And the focus a lot on quality control is, setting limits or, kind of risk assessment and how often we should run things. But this particular concept usually winds up being maybe a paragraph in an entire book. I'm going to throw up a couple other CLIA regulations that are kind of related to this. This D5403 or 493-1251. This is what must be included in procedures. And that would be like control procedures and corrective actions that you take. These are things that are required to be in policy. You should have this in your laboratory policy for, any assay that you're running quality control on. These are what we call responsibility tags, or these are part of the CFR that these different CLIA positions are responsible for. It's like the laboratory director must ensure that necessary remedial actions are taken and documented whenever significant deviations from the lab's established performance specs are identified, and that patient test results are only reported when the system's functioning properly. That's a lab director responsibility. Each position in CLIA has different responsibilities, and this also shows up in our technical consultant, technical supervisor, general supervisor. If you're not familiar with the CLIA subpart M, the technical consultant is a moderate complexity consultant position, and technical supervisor is the high complexity version. They're kind of two sides of the same coin. And there's slightly more stringent requirements for high complexity than there is moderate complexity, but they're both really challenging positions that many of you may be working in already. And an obligation there is ensuring that the patient test results are not reported until all corrective actions have been documented and the test system is functioning properly. So this was kind of some tips for reviewing QC in general. We'll kind of start kind of high level and then we'll drill down into this concept. One thing that we find a lot when we're reviewing QC is that maybe if we don't have a good quality control program in place, labs may not have encountered this issue because maybe their quality control isn't quite capturing when an assay is slipping out of control. So, when we speak to labs or when we're surveying, we ask like, how many controls do you run? How often? Really one of the big important ones is how do you determine what is acceptable? Like Westgard, there's a lot of emphasis on warnings versus failures based on statistical analysis. And then the kind of last question at home: what do you do when it doesn't work? So this was a great example. This was a laboratory I was in, and the quality control was sitting, very comfortably within 1 SD, slightly above the stated mean. And this is something for an inspector that sets off little red flags in our brain. And I'm kind of go into detail here. Here's another CLIA reg. This is, I think it's D5783. This is, what's the requirement for setting acceptability criteria? Basically, the premises that will have statistical parameters. It's usually mean and standard deviation. That's not the only way to do it. That's probably the most popular method. But the premise that you have statistical methods to kind of monitor your quality control. And the reason that's so important, well, I'll get into that here in a second. Here's another thing that we find pretty often. This was some person had calculated ranges on their biorad. A lot of folks have biorad or MAS in their freezer. And if you've got assay controls, you can, if they're specific to the instrumentation and methodology, you can use those, manufacturer stated ranges to set your criteria. One of the issues, not a problem, but one of the things that we see a lot with biorad is that the stated ranges are plus or minus 3 SD. And a lot of folks, when they are calculating them, they misinterpret them as being 2 standard deviations. And when you do that, you're unintentionally setting your 3 SD much wider. And if you're using like a 1-2S as a warning, that's really a 3 standard deviation failure, and you've missed it, and you may have been running out of control for a long time. So this is one thing that pops up a lot. This is out of Wikipedia. I just thought this is a great way to kind of think about the statistical end. And when we're reviewing QC, this is kind of what we're looking for. So if I'm looking at a month of QC, I'm expecting about 1 in 3 results to fall outside of 1 standard deviation. It doesn't have to work out that perfectly. It's kind of like flipping a quarter. But if I've got 30 points and nothing's outside 1 standard deviation, then what the laboratory is calling 1 standard deviation is not 1 standard deviation. And again, like 2 SD, roughly every 22 points, 3 standard deviations, about 1 in 370, or about once a year. And that's just the opportunity due to chance alone. It may not work perfectly in that ratio, but like that first picture I showed, if we've got quality control that's comfortably within 1 SD for 90 days, then what we're calling 1 standard deviation isn't accurate. Another thing that from the regulatory side, when we're doing inspections, or if you're managing your quality control program and you're having to review things, we really kind of want to drill down when we found problems. And so I've circled a couple of clusters here where you can tell the scientist had some out of control values. You can see some bias here. So there's some bias in the positive direction. I think this is vitamin D. And you can see these little clusters of points where they had repeated the control a number of times, and it never really kind of came in. And this is a kind of situation that we want to kind of drill in on. Because this assay, appears to be out of control a number of times. So, what are we looking for? We're looking for, what's the acceptability criteria? Is that even appropriate? We're looking for, are we documenting all the corrective actions? We always tell folks, tell your story. You want to document everything that you had to do. If you repeated it and it worked, that's great. If you had to get another control out of the freezer or the fridge or reconstitute, if you had to do a maintenance procedure, if you had to recalibrate, if you had to replace an assay, if you had to stand on 1 foot, That's what I always felt like with my coag analyzer. I had to stand on one foot and load it just a certain way. But tell your story. What did you have to do to get quality control to get to come in to control? When we have QC failures, the way we kind of look at them is they fall into two categories. We've got a problem with the quality control material or a statistical outlier, right? So if we're using statistical measures and we have a value outside of 2 standard deviations, there's a 1 in 20 or 1 in 2022 chance that is just strictly due to chance. And a lot of times, if it's just a statistical outlier, simply repeating the control, it'll come back in. The other thing that happens a lot, probably more likely, is that we have issues with the quality control material. Maybe it's past its stability, maybe it hasn't been stored properly. I think everybody's worked a shift where the shift before left it out the entire time at room temperature, or it was something that was, photosensitive and it's set under a fluorescent light all day, and then you come in and it doesn't work. Evaporation, contamination, those are all things that can happen to quality control material that will, cause you to have failures. That's one category. The other category is we have some genuine failure in the analytic system. It could be a reagent stability. It could be a bubble. It could be cow drift. It could be a mechanical problem. Somebody put a tube on there that had a cap on a analyzer that doesn't have cap piercing, and maybe they didn't do what they were supposed to do, and you came in behind them, and now you've got this misaligned probe or leaks in tubing. Any of these number of things, and your quality control actually caught the problem. Like, this is what you want to do. You're taking a snapshot at any given moment, and your snapshot, showed you that you have an actual issue. So this is kind of where we split into this concept. When do we need to evaluate patients since the last acceptable QC or calibration? And when the QC failures fall into that second category, that's when we need to be looking at patients. If it's a statistical outlier, or if we're able to fix the out of range control by replacing a control material with something that's within stability or has been treated appropriately, it's kind of a no harm, no foul situation. But if we had cow drift, or if we had a mechanical issue, or leaks, or bubbles, or assay stability, we don't know at what point that assay started to be problematic. We know it's problematic now. We've taken corrective actions to fix things, and we're comfortable that going forward things should be good. But the last time that we knew that assay was in control was the last time QC or calibrations passed. Depending on the setup in your laboratory, that could have been 8 hours ago, that could have been 24 hours ago. There's a lot of risk-based ideas about how often you should run quality control. CLIA requires like 2 levels every 24 hours, except for in certain cases like coag or blood gases, where a little more stringent. Your manufacturer may require it every 8 hours or something along those lines. But if you have high volume and you have to make risk-based decisions, you may have more frequent quality control. And oftentimes we find laboratories are running the bare minimum, and this can make it problematic when it comes time to assess patients. Here's another example. This is a PT example. Try to blur out the name of the facility there. They had missed 4 out of 5 on total protein. This particular, you can see there that on the right-hand side, the SDI, that's the measure of how far away they were from the mean of the group. They were 6 standard deviations away from the mean of their peers on 4 out of 5. When we looked at the corrective action for this failed PT, they said since all the other results were within limits, it must be a sampling or random error. So let's talk about the random error. If it's 6 standard deviations away from the mean of the peers, there is a 1 in like 5 billion chance that these are going to be just due to chance alone. That if you ran it every day, it'd be once in 1.38 million years, or twice in the history of humankind, that this is just due to random error. So it's not very likely. What's more plausible is that we had an actual, analytic failure somewhere along the lines. And in this case, this particular laboratory had exceptionally wide, quality control acceptability criteria. They had not caught that their assay was out of control. This was on a platform where the calibration would print out metrics, but it would not tell if you had passed it, failed. So you had to evaluate the metrics every time you did a calibration. And when we found the calibration that happened about 2 weeks before this PT had been run, the calibration would have not passed the manufacturer's requirements. It would have been a failing cal. And so there was multiple opportunities for them to maybe have caught this analytic failure, but it just did not work out quite that way. And so, on this case, when we have a calibration issue, and this quality control records weren't catching these issues, we have a lot of patients to remediate because this was significant bias. So all those patients back to that last acceptable calibration needed to be evaluated. And if treatment decisions were made based on that, those providers need to be notified. And this is usually something your lab director will help you with. If you're a lab director, this is something that you're going to have to maybe talk to your providers with. And this is kind of a hard position for a laboratory to be in, to have that level of transparency when you've made a mistake or when something's happened. Here's another example. Oh, this one, yeah. So basically, this was the story. I'm just told I got ahead of myself on the slides. Yeah, this was here's our statistics, and here's our R value down here that would not have met the manufacturer's requirements. There's a 0.963. It had to be 0.99 to 1.0. If they had caught this in time, they stood a chance to have remedy the situation. But there's multiple layers there that kind of led to these failures. One thing about putting patient remediation in policy. So now that we found evidence of non-compliance, and this is like for us when we've sent out a report, the laboratory has to respond. And this is an uncomfortable position if this is new to you. Especially if you're doing any volume at all, a lot of labs want to evaluate, a percentage of patients in an unsuccessful run. So, let's say my QC has failed and I had to recalibrate, and I ran 100 total protein samples between yesterday when QC was acceptable and today when I had to do all these corrective actions. Am I supposed to, evaluate every one of those 100 patients? Like, yes, it's not acceptable to go back and randomly pick a percentage of patients. It's not acceptable to evaluate random patients. A lot of times labs want to, I'll pull 10, I'll pull, a random 10. Other labs too will say, well, we'll rerun all the patients from the unsuccessful run. And there's kind of some problematic pieces to every one of these strategies. If we're evaluating a percentage of patients, it may not be useful if the analyte issue is on one end of the reportable range, so like cal drift. I'll give you a couple examples too. Like evaluating random patients, the part of the issue with this requirement is that, and the reason that this falls on lab directors and consultant supervisor positions is because you kind of need to know what the problem was. Was it a mechanical issue? Was it a precision issue? Was it a cal drift issue? Because if you're just evaluating random patients, you may not, pick up on the patients that could have been compromised. And the problem with rerunning all the patients in an unsuccessful run is that sometimes it is just not, within stability. Thinking about limited stability assays like serum ethanol or ammonia or PTT on heparinase patients. Those are supposed to be good for like 1 hour. We run QC every 8 hours on coag. I've got a sample that is 7 hours beyond stability by the time that I've, at a minimum that I've caught that I have an issue with my PTT assay. Do I rerun the sample on a sample that I know is outside of stability? And what do I do with that result if I get one? I'm going to issue a corrected report on a sample I know is not stable. So that's not a good metric to use either. Evaluating the percentage of patients in an unsuccessful run. One of the best examples I've run into was a laboratory that the creatinine failed. Creatinine failed on level 3, which was the high level. Level 1 was in. They repeated it. It was still out. They changed the quality control material. It was still out. They recalibrated the assay. Everything came back on the mean. And we're looking back at patients, back to the last acceptable QC. All of our level 1, which is where on creatinine, this was like our normal range, our patient normal range, medical decision limit. The assay was never out of control at that spot. The assay was out of control in the upper end of the reportable range, at the upper end of our medical decision limit on that level 3. When we're evaluating patients back to last acceptable control, we may not have had any patients. Well, one, we may not have any patients tested, but the other thing is we may not have had any patients that fell in that upper end of the reportable range. So just a random sampling or a percentage of patients is not going to identify any issues there. I want to go back and I want to look at anybody who might have been sitting around that level 3 value. And that's what I want to drill down on, because I know that it was a cow drift issue. I can think of some platforms that have multiple sampling pipettes. If one pipette gets clogged, and that's the one that you fail QC, and maybe you have to do some flushing or replace a pipette, you're going to want to identify patients that were run on the problematic pipette. Maybe it was fine on the other pipettes. There's a number of different things that can happen, and it's going to be a case-by-case basis, and you really have to kind of troubleshoot what the actual problem was. So as far as putting into policy or putting it into forms, there's just not really a good, easy formula. We encourage laboratories to put this on these leadership positions, and for these people to make good decisions. This is a good opportunity, and this is why these CLIA regs on these TC, TS, GS, lab director, why these positions have that burden of responsibility, because these are the folks that we trust to really drill down on what the problem was. The other thing I want to say is that it's really important for laboratorians to be following their policy for troubleshooting. Sometimes it's very tempting to go to the thing that you're sure will fix it. QC's out, I'm not going to repeat it, I'm not going to get a new QC, I'm just going to recalibrate the assay and go. Don't do that. Follow your laboratory's established policy. If you don't methodically work through the problem, then you don't know what happened. It is going to be very challenging to assess patients back to last acceptable control and determine if there was any patient impact. Other part of it too is that occasionally an assay will be slightly out of control, and you may not, maybe you are able to repeat some samples, or maybe you're able to evaluate the patients, and a difference would not have changed any treatment outcome or anything like that. There's another opportunity there to document that and make sure that you may not need to issue a corrective report, and maybe within what's normally bioavailable, right? So that's why it falls kind of on these positions. I just want to remind everybody, you're probably doing great. If there's questions, I'll be happy to take those at this time. Like I said, I'm kind of spreading the gospel, and I'm a big fan of this. Here's a couple of references I threw in here, from Westgard and a couple of other papers, and obviously on the CLIA interpretive guidelines. And I'll be happy to answer any questions. I'll do the best I can.
Just unmute yourself if you have some questions, or I'm looking here.
In the chat.
Hi, this is Denise. I just
Hi, Denise.
want to say thank you. I'm a blood banker who's going to be teaching chemistry this fall, and this is it was very timely. So thank you for this. I appreciate it.
We find this a lot in chemistry, but it affects anything that you run quality control on. And I just share like a personal anecdote. When I was lab manager, I had a coag instrument that was basically contaminating my PTT reagent with some other reagent, probably recomboplastin from PT. And my QC was every 8 hours, and it would be, comfortably in control, 2 out of 3 times. And then we'd run it on day shift, and it'd be 19 standard deviations away from the mean. It didn't fail a little bit. It wasn't out 3 SD, it was out 19 SD. It was a catastrophic failure. And what it was is it was contamination of the reagent, entirely. So we wound up having to, make some risk-based decisions. This comes up in chemistry and coag, where we were, for a time, we were having to run quality control with every single patient run. we've been doing some large COVID labs recently, and these high volume, testing facilities. The really good ones, I've got one lab I love to go to because they're so fantastic. But they run thousands of samples a day, and they run quality control every like 500 patients because they want to capture anytime that assay is out of control, and they don't want to have to remediate thousands. It's a whole lot easier for them to go back, 3 hours later, while everything is still within stability, and come back and like I said, this thing just affects any part of the lab where you're running quality control. You're having any quantitative anyway. I say that quantitative, but it matters to qualitative too. If you've had a kit, a lot of people have established IQCP since 2016. Maybe you're running 30 days between quality control. Like you could run a lot of patients in 30 days. So anytime we have these QC failures that are honest analytic failures, it's just such an important concept. And please take this to your chemistry students. Take it and spread it far and wide. Like I said, I'm spreading the gospel.
Exactly. I used to be the day tech and the night tech. We couldn't understand the QC was different from the day to the night. And then I watched him. He was using literally the same pipette to, reconstitute the controls. And I'm thinking, no.
It manifests in so many places, and it's you can get comfortable and things will be going fine, and then you spring a leak, you get a bubble, you contaminate with a pipette. I know I've worked in a lab where pipettes were shared between departments, and occasionally somebody would get a little aggressive with the whole blood, and it would start clogging up the bottom of like a little MLA pipette. And then you come back around and use that same pipette to reconstitute a control, and so now you've got a QC failure. But if you got a QC failure and it's just your quality control that's the problem, then if you're able to identify it's a statistical outlier, it's just the control, you don't need to remediate patients. But maybe you use that same pipette to reconstitute reagent, and now you've got a reagent that's out of control. Like this is when you want to go back and make sure that there's no patient harm done. That's really what it's about. It's making sure that the results are accurate, and that we're not doing anything that's actively harmful. Anybody else?
Hi, I was wondering, can we get a copy of this presentation? I've been I decided to listen to this in my office at work as a new lab director. We had a code come in. We have units being transfused. So I've been getting called out half the time during this presentation.
Yes, this is being recorded. So this will be available. I think Debbie said it'll be available on the website.
Okay, would we be able to get a copy of the PowerPoint?
Could you do a PDF of the slides for us, Casey?
Sure, I don't mind doing that at all.
Okay, that would be great.
Yes, because I was really looking forward to this one because the lab I'm in my 4th week here as this program director, and they've had Westgard rule violations happening, standard deviations not set right, means not correlating with the standard deviations that were set. So I been a little busy. So
well, congratulations on your new role, and it sounds like this maybe was pretty timely for you too. So
I know, I was like, I think he knew exactly what I needed to hear. So my question kind of on that. So kind of what's been being done is the means were being adjusted with new lot numbers, but the standard deviations as far as the distance they are from the mean were never being changed. They were told they stay the same for the life of the analyzer. And I was like, no,
so there's a lot of, that's a whole other rabbit hole and a whole other presentation, but there's a lot of folks and, that find a lot of value in using historical limits. If you're able to collect, in your laboratory with your personnel and your environment, your honorary instrument, how does the total protein assay function in your laboratory? If you're able to collect, say 20 points to set a mean, that 20 points is going to, statistically set you a very narrow acceptability criteria. If you're able to collect 2,000 points, or 20,000 points or 200,000 points, you'll eventually get a point of diminishing returns that can kind of help you use historic limits to set, but there, by all means, there's, especially if you've got assay controls, those are fantastic. A lot of folks don't buy them because they usually cost more. Sometimes they're not available for your platform. Assay controls are an option.
One of the first things I personally noticed was the Levy Jennings were ugly. I mean, so ugly. And when I looked at what the manufacturer expected ranges were and what our observed ranges and setting off of our observed, they were way off from what they had as the expected. And I looked in one night, they had over 30 Westgard rule violations, and it's usually all 10x. They're all running above. So when you showed that first picture about what's wrong with this, I was like, oh my gosh, I think you pulled that from our chemistry stuff.
There's when you say that, like the Levy Jennings looks kind of wild, that's another kind of great opportunity to use that statistical analysis or statistical expectations. In that particular one, there was not a single value outside of one standard deviation. That's just statistically kind of unsound. We don't expect that, but if every value is up and down outside of 2 or 3 standard deviations, and we're monitoring our metrics, right? So if our CV is comparable to what the manufacturer claims on the precision, maybe we've set our ranges too tight. Sometimes we can, create problems for ourselves by making ranges too tight, and we have, it's all about, again, it kind of comes back to an argument about risk, but you want to accept as much good data as possible and reject as much bad data as possible, and you kind of have to find a middle ground, especially when it comes to establishing your own ranges.
Right.
We want ranges that identify honest, analytic, out of control failures, and we don't want to reject so much good data that we waste reagents and tech time and calibration materials, and so it, from the 30,000 foot view, sounds like
calibrators like crazy. I've never been anywhere where they calibrate so much or reconstitute QC. So right now we're kind of going through and looking at the manufacturer's expected ranges and kind of readjusting, and then looking at our observed and tightening in. So am I going kind of the right path on trying to correct these issues?
Yeah, and the other thing to look at too is always pull your instructions for use from the manufacturer. They will, every one of them usually has like 4 pieces in there where they will explain the manufacturer's studies and how they determine that their assay is accurate. They'll set the expectations for what they expect is, precision is capable of. They'll explain how they came up with their reportable range, and they'll usually have some kind of method to describe interfering substances or limited detection, and big ones, patient normal ranges. And especially when you're trying to evaluate quality, like that's a good place to start, is to go back to that instructions for use, and are you getting comparable results or not? And if you're not, maybe it's time to get some technical assistance. If you are, maybe we've got some other issues going on as far as like setting limits.
Okay. Well, we're looking better when I look at manufactured expected. I've been pulling all those. When I look at observed, when I go back and look at peer, we're running pretty good. But when I compare it to what our expected ones they have set in there as expected ranges and our LIS, it's ugly.
Yeah, and then another challenge too. A lot of folks, having to kind of set one set of limits, right? So sometimes you have limits in your LIS, and sometimes you have limits on the analyzer. And if you can, either having to pick one or the other, or making sure at a minimum that they match each other. I know this comes up a lot when, maybe they're set in an LIS and there are there's limitations between the 2 platforms.
Mm-hmm.
Maybe it's as simple as a decimal point. Maybe it's in on the analyzer and out on the LIS. Well, I guess it'd be backwards. Maybe it's in on the LIS but out on the analyzer, or things like that. So yeah, there's just quality control is such a bear, and it's so important. And kind of like tying back in with this presentation, like when we have these honest failures, this is our opportunity as laboratorians to make sure that we're turning out safe and reliable results. And it's kind of hard sometimes to have to, have that conversation and work backwards. Did we turn out any results in the last 8 hours or 24 hours that are questionable? And let's evaluate them, and let's make the appropriate remedial actions, and let's document it.
Yes,
So,
we've actually done a couple patient look backs, and it does,
yes,
patient testing has not been affected, but they had never really heard the term patient look back before, even though sometimes they've been doing it in the past. They kind of knew enough that, hey, we should check these, but no documentation of it. So that's implementing that. And so this was like right on the nose for.
And two things that seem to happen a lot with that is some folks may have some experience with this concept. One thing that happens is maybe you have like a genuinely catastrophic failure. I worked at a small lab that, we worked on a platform that sodium was just, it became wildly unreliable. And in those cases, I do remember going and doing some patient lookbacks, but the premise here is that, we're setting a quality control program. This isn't for those extreme cases. This is for every case. Anytime we have quality control failures that require us to make those analytic manipulations, we're obligated every time to assess all the patients. So maybe they have a little experience with this, but maybe they haven't really had an opportunity to understand how important this is all the time. Congratulations on the new role, though. That's always great.
Thank you. I'm questioning it sometimes right now, but no, I'm enjoying it.
Thanks, Vanessa. Any other questions? Put them in the chat.
No, and they're not in this chat. So if you want to show your slides, Stephanie, with the code and everything on it.
Good. Thank you, Casey. All right, so the PACE code is going to be N as in Nancy, M as in Matthew, L as in laboratory, 22. Again, N as in Nancy, M as in actually medical, L as in laboratory, 22. And again, we thank Casey Laird for his time and
Yes, thank you.
all his knowledge on this topic. This has been very helpful for everybody. So we greatly appreciate you coming in and doing this for TACLS.
Thank you so much for the invite. I really enjoyed it.
Now, before everybody leaves, we want to give you a quick update on the upcoming events for TACLS and ACLS. Again, TACLS is going to have its annual convention in September 25th to the 27th. It's going to be in Galveston. You can go to the TACLS website, tacls.org, and you can see the hotel. You can see all the information. Speakers and sessions will be uploaded there as well. This is a great opportunity to get CEs and network and have a great time. So we hope to see you guys there. We're excited. It's been a long time coming. So I hope to get some new faces out there and bring in new members. Again, that's TACLS for the state convention. Now, National ASCLS, the joint meeting is going to be in Grand Rapids, June 26th to the 30th. Early registration ends tomorrow. Is that right, Debbie?
The early bird. And
Early
then,
bird registration.
right. If you wanted the $100 discount, it ends tomorrow, and you can sign up virtually or in person. So if you don't, you can also do the national meeting by virtual. So you can, that'll be nice for people.
Yes, and it's very intuitive app. It'll show all the sessions. It can ask you which ones you want to join, and you can just view the presentations that way. So it's pretty good if you guys ever want to do it virtually. But of course, we would love to have you there. All right. Did everybody else got the PACE credit? Okay.
And Casey, I guess you probably have Stephanie's email. If you'll do a PDF of your slides and send it to her, then we can forward it to people. Okay.
Absolutely. Absolutely.
And thank you again. I liked your gospel.
Thank you. Thank you for the invite. I enjoyed it.
All right, everyone. Have a great evening. Thank you so much for your time. And we look forward to seeing you at our state convention. Take care.
Thank you.
Thank you.